Right. Good morning to all of our viewers, and we're going to start off the day, the second day of this conference, the Ceylon College of Physicians Annual Conference 2020. And I'm Dr. Dilshan Priyankar, and we're going to start off with a teaching capsule. And we have with us Dr. Udul Hewage. He's a senior consultant physician in the Division of Medicine and Critical Care. And he is going to talk to us on glycemic control in critical ill. And over to you, Dr. Hewage.
Thank you. At the outset, let me thank Sri Lanka College of Physicians, its president and the organizing committee for inviting me to give this talk today. I was told that this is an interactive session, but unfortunately I cannot be present in person. So I was thinking how I sort of interact with the audience. I thought the best way is to have a multiple choice question, one question with 5 responses. So if you can answer and if you can vote your answer, don't worry, even if you don't know the answer, doesn't matter, but you select whether it's true or false, and I will go through the lecture and I'll cover all the responses in my lecture, and then we will have the same question at the end, and to see how much you have absorbed. All right, this is the question. Let me share the screen. Um, so it's a true false a question. The first response is stringent glycemic control in critically ill patients across the board has been shown to reduce mortality. I don't know whether you can see the question on the screen.
Yeah, we can see the question.
You can see the question. All right, that's good. So it's a true false question. All right. Can I have the second poll, please? All right, great. Results of major randomized control trials on glycemic control in critical ill patients are in agreement that intensive insulin therapy improves prognosis. Again, true or false? Great. Let's have the third response. Treatment with SGLT2 inhibitors have been shown to improve cardiovascular mortality and morbidity in critically ill patients. Great. Can you have the next poll, please? There is unequivocal evidence supporting a causal relationship between high blood glucose levels and increased risk of mortality in critically ill patients. Great, thanks. Can we have the last poll, please? Critical ill patients without a prior history of diabetes or pre-diabetes do not develop hyperglycemia during acute illness. Thanks. Thank you for that. All right, let's start the talk. And so next 30 minutes or so, I will skim through the background. Then I will give you an account on stress-induced hyperglycemia, what it is, and also we'll discuss the management of hyperglycemia in critically ill patients, look at the evidence for and against tight glycemic control versus moderate glycemic control, and then I will wind it up by giving some take-home messages. When we look after patients who are critically ill, who are very unwell, particularly in the ICU setup, it's not uncommon to see when you check the blood glucose level, most of these patients can have high blood glucose level. These patients either have a prior history of diabetes or some form of pre-diabetes, such as impaired glucose tolerance or impaired fasting glucose. And a significant proportion of these patients, even though they have hyperglycemia or high blood glucose level, there's no prior history of diabetes or pre-diabetes. For the first time, that their blood glucose level probably would have increase during that critical illness period. Now, that is the category is known as stress-induced hypoglycemia. Uh, there is enough evidence to suggest that hypoglycemia in hospitalized patients is strongly associated with increased mortality in a wide range of patient group. These include patients with high blood glucose level, whether it's diabetic hypoglycemia or stress-induced hypoglycemia. Furthermore, having high blood glucose level tend to increase certain complications. These include increased incidence of infection. It may be, say, if it is a post-operative patient, it increase the risk of post-operative infection or just general sepsis, critical illness, polyneuropathy, acute kidney injury, and most of these patients tend to have low hemoglobin requiring blood transfusion. And also, these patients tend to stay in ICU, and the duration of ventilation is longer than when you compare with patients with normal glycemia. There's growing body of evidence suggesting that stress-induced hypoglycemia and diabetic hypoglycemia are not the same. They are two distinct categories. Association between hyperglycemia and mortality is stronger in patients without known history of diabetes. In other words, the association between hyperglycemia and poor outcome is much more stronger in patients with stress-induced hypoglycemia than diabetic hypoglycemia. So it suggests that these two entities are not the same. Why people develop hypoglycemia during acute stress, particularly during acute illness, and especially when they are critically ill. Again, the exact reason is not very clear. However, the most likely hypothesis is that increased counter-regulatory hormones and inflammatory mediators. We know that when someone who is very unwell, the counter-regulatory hormone response is very strong. Say, for example, these patients tend to have very high cortisol level. They tend to have high catecholamine and growth hormone levels. And all these hormones are, as you know, are diabetogenic. They tend to increase the blood glucose level. Furthermore, the inflammatory mediators such as cytokines are associated with interfere with insulin response, and it mitigate the peripheral insulin sensitivity or enhances peripheral insulin resistance. Thereby, the peripheral tissues are unable to take up glucose. And also, it has been found that cytokines increases hepatic gluconeogenesis and hepatic glucose output, and this results in hyperglycemia. Even though there is an association, strong association between hyperglycemia and poor outcome in critically ill patient, whether there is a causal relationship exists or not is not known. It may well be a surrogate marker of the severity of the illness. So it may not be there may not be a causal relationship. It's just a marker of the severity of illness. Let me introduce to you another concept called relative hyperglycemia. What is relative hypoglycemia is acute rise in blood glucose level because of stress hypoglycemia over and above the background level. So it could be a diabetic hypoglycemia or stress-induced hypoglycemia. So if a diabetic patient who comes to the hospital with acute illness or critically ill, and their blood glucose level tend to be significantly higher than their normal average blood glucose level. So that is the relative hyperglycemia. It has been shown that relative hyperglycemia is an independent risk factor for inpatient mortality among patients who critically ill patients. This is one of the studies at our center looking at the relative hyperglycemia as an independent determinant of in-hospital mortality in ICU patients. Um, as you very well know, when a patient is very unwell in the ICU, there are a lot of things happening. In the midst of all these intervention, the glycemic control is one of the most important aspect of management of such patients. Both hyper and hypoglycemia are independently associated with increased mortality. Therefore, what we try to do when we manage hyperglycemia in critically ill patients is that try to avoid a very high or very low blood glucose levels. Let's look at some evidence. A landmark trial, which was done in 2001, I think it was done in Belgium by Vandenberg and group, was the first to demonstrate a significant reduction in mortality and morbidity when you treat critically ill patient with hypoglycemia with intensive insulin therapy. This is a single center study involving exclusively a cardiothoracic surgical ICU patients. It's a cardiothoracic intensive care unit. 2/3 of patients who were recruited for the trial have undergone cardiac surgery, elective cardiac surgery. So it's a very specific group of patients. And this factor is important when we talk about applying this evidence into more broader patient population. So in this randomized control trial, there were two arms, the conventional arm and the intensive insulin treatment arm. Patients who received the intensive insulin treatment, the blood glucose target was to keep it between 80 and 110 milligram per deciliter. The conventional arm, the insulin infusion, was commenced when the blood glucose level goes above 215 milligram per deciliter. The blood glucose target for the conventional arm was between 180 and 200. See, there's a significant difference in the blood glucose level between the two arms. The aim of this study to determine whether intensive insulin therapy is associated with any mortality benefit. What they found at the end of the study was that those in the intensive group showed 42% relative risk reduction in mortality in the surgical ICU patients, as well as in hospital survival. So there is a very significant reduction in mortality, both when the patient is in the ICU and once the patient is discharged from ICU to general medical ward, still that mortality benefit was seen. So this is a result in a graphical form, a significant reduction in improvement in survival or reduction in mortality in intensive arm, both in ICU and general medical ward. So significant reduction in mortality and morbidity, and the greatest reduction in deaths for patients with sepsis and multi-organ failure. Out of all the patients who had sepsis and multi-organ failure had the highest relative risk reduction. Treatment benefit was largely among the patient without prior history of diabetes mellitus. In other words, patient who had stress hypoglycemia had the highest reduction in mortality in this particular study. As you know, a 42% reduction is quite significant, particularly in this cohort of patients who are critically ill. There are very few interventions which has significant mortality benefit. Therefore, the medical community embraces this study very well, and very quickly they translate these evidence from research into their clinical practice. As a result, the guidelines changed, and if you look at the guidelines in early 2000, the surviving sepsis guideline, they changed from moderate glycemic control for critically ill patient to a very strict glycemic control using intensive insulin therapy, just based on this particular study. Unfortunately, though, the subsequent large randomized control trial, and in other trials, they involve not only surgical patient, but also medical, as well as mixed medical and surgical ICU patient. And these trials fail to replicate the same results that the Belgium group achieved when they did this trial in 2001. In light of this conflicting evidence, another trial was carried out. The acronym for the trial is NICE Sugar Trial, Normoglycemia in Intensive Care Evaluation and Survival Using Glucose Algorithm Regulation Trial. This again was a large a multi-center randomized control trial involving 3 countries, Australia, New Zealand, and Canada. They recruited in excess of 6,000 patients, very similar to Belgium study, 2 arms, the intensive arm and the conventional arm. Now, the intensive arm, the blood sugar target was between 80 and 108, and the conventional arm, the target was less than 180. But this is the difference between the Belgium study and the NICE sugar study. If you remember, the Belgium study, the conventional arm, the blood glucose level was kept between 180 and 200. Here, the blood glucose level is significantly lower in the conventional arm, that was less than 180. So again, this factor is important when we interpret these results, and also when we compare these 2 trials. And I will discuss that in a bit more detail in future slides. Now, this is a graphical representation of the same data, a significant reduction in blood glucose level, average blood glucose level in the intensive arm was around 107, and the average blood glucose level in conventional arm was around 142. So what did they find is that there is a significant survival benefit for patients who are in the conventional arm, now compared to intensive arm. Now this is a complete contrary to the finding of the Belgium study, where they found that intensive insulin therapy is associated with a significant improvement in hospital mortality. And this study found complete opposite of that. And this difference between the 2 groups are statistically significant as well. So now we are left with a bit of a conundrum. We don't know which one to believe. Perhaps NICE study, NICE sugar study has more patients. It's a multi-center study and more variety of patients. The mixture of different ICUs, including both medical and surgical ICU patients. So probably these results are a bit more robust than the Belgium study. The treatment effect did not differ significantly between surgical and medical patient and patient with and without prior history of diabetes in this particular study. And there's a significant increase in severe hypos in the intensive group. So that is one of the prominent feature highlight in NICE sugar study. The intensive group had a significantly higher number of hypos. So that perhaps would have led to this difference in the outcome. There's no significant difference between the 2 treatment groups in median length of ICU stay or hospital stay. There's no difference in the median length of mechanical ventilation or renal replacement therapy in contrast to what we found in the previous study. And subsequently, there were a number of other randomized controlled trials looking at the same outcome, failed to replicate the results that was found in the first trial that was done in Belgium. So all this, most of the trials shows either there's no benefit, and some of the trials shows that in fact, it increased the mortality in the intensive arm and also significantly higher number of patients in the intensive arm had significant hypoglycemia. And the findings of nice sugar study and other randomized control trials was supported by several meta-analyses as well. The other thing that came into the picture or came into the light is that glycemic variability has been a significant risk factor for poor outcome. It's not only hyperglycemia or hypoglycemia, but also the fluctuation of blood glucose level has been found to be an independent risk factor for poor outcome. This is the forest plot from one of the meta-analysis. This particular meta-analysis look at the trials involved in mixed ICU patients, medical ICU patients, and surgical ICU patients. They divided into different groups based on the patient cohort. And if you look at the mixed ICU, the final result shows that there's no significant improvement with intensive insulin therapy in terms of mortality benefits. And the same it is true for medical ICU patients. There's no significant difference. Whereas if you look at the bottom part, that is surgical ICU patient, there is a difference. There is a difference in the sense that there is an improvement in the mortality, those who receive intensive insulin therapy. So hypoglycemia is one of the main problems with tight glycemic control, and it has been found that hypoglycemia is an independent risk factor for poor outcome. So a systematic review looking at hypoglycemia and mortality found that strict glycemic control with intensive insulin therapy is associated with greater risk of hypoglycemia without having significant beneficial effect. In fact, it can be detrimental to the critically ill patient. So this is what is the same thing in a forest plot form, and find that on to your right hand side, it favors the control. On your left hand side, it favors the intensive insulin therapy. Now this shows that there is a significant risk of hypoglycemia when you start this patient on intensive insulin therapy. Now, if you look at why the difference in outcome between the studies, as I mentioned earlier, the Belgium study has totally different results compared to nice sugar study. In part, it could be attributed to a different patient cohort. And the first study, the Belgium study, it's exclusively cardiothoracic patients were looked at, whereas the nice sugar study included mixed bag of both surgical, medical patients. And also intensity of monitoring. The Belgium study, the intensity of monitoring was quite robust, and the rate of hypoglycemia was less compared to other randomized controlled trials that probably would have contributed to the results that they got. And again, there's considerable variability in what constitutes a usual care. That's the control. That is to say that the blood glucose level or blood glucose target for the control group is significantly higher in the Belgium study compared to the other studies. All these factors would have contributed to the discrepancy of those results. when it comes to glycemic management in the critically ill patient, um, the consensus, even though the evidence are conflicting, the consensus is that the insulin therapy should be initiated for treatment of persistent hyperglycemia over 180 milligram per liter per deciliter. And the majority of patients, the target glucose range 140 to 180 milligram per deciliter um, would be suitable target for majority of these patients. However, though, more stringent goals for selected group of patients, for example, perhaps maybe patients without history of prior diabetes or patients with stress-induced hyperglycemia, they probably might benefit from more stringent blood glucose control, and also specific groups such as patients who are in cardiothoracic unit, who are after major cardiothoracic surgery, perhaps should have it more stringent glycemic goals, such as 110 to 140 or so. But more important thing though is that the time in target blood glucose range, try to keep it most of the time, try to keep the blood glucose level within the target range. If you can keep time in target blood glucose range over 80%, it has been shown that it is associated with lower risk of mortality and morbidity. There are certain group of patients you would adopt a less stringent approach. These patients include patients who are terminally ill. What you are looking at is just reducing symptoms related to hypoglycemia, or patients with severe comorbidities, particularly history of severe cardiovascular comorbidities are the patients who tend to have higher mortality when you start treating this patient with intensive insulin therapy. And if you don't have facilities for frequent blood glucose measurement and constant supervision along with adjustment of insulin infusion rate, please do not start intensive insulin therapy. And certainly palliative care patient, what you need is just a symptom control. So you need to use your clinical judgment when you institute a management plan for hyperglycemia in critically ill patient. And you need to continue with assessment of clinical status, which include look at the trajectory of blood glucose measurement, early detection of the trajectory and early intervention can prevent a big fluctuation and help with the early recovery as well. And then the illness severity, more severe the illness, tend to have high blood glucose level and need more constant supervision including constant adjustment of insulin therapy. And then, of course, you need to look at the nutritional status of the patient, whether the patient is completely parenteral or not. Again, has a bearing on your insulin therapy. And then concomitant medications such as steroid. If you start steroid and you know that it's certainly going to increase the blood glucose level, so you need to preempt and adjust the insulin therapy when as you start this medication, or when you wean off steroids, blood glucose level tend to go down, so you have to be careful to avoid hypoglycemia as well. So blood glucose monitoring is an important part in managing these patients. The hospitalized patients who are not in the intensive care unit, who are not critically ill, who have their normal meals, blood glucose measurement about 3 to 4 times a day, probably 4 times a day, would suffice. And you can use the glucometer, and or point of care measurement is quite good enough. But people who are not who are on enteral feeding, you may need more frequent blood sugar measurement, maybe 4 hourly or so. And certainly when the patient is on intravenous insulin infusion, The blood glucose measurement should be done at least every 1 to 2 hours. And also need to follow all the safety standard when you monitor blood glucose level, not to use the lancet or the needles to prick multiple patients, etc. The continuous blood glucose measurement is a novel way of measuring blood glucose level. It measures a tissue blood glucose level. It helps you to get more frequent measurement of interstitial glucose level. One of the problem with the finger prick blood glucose level is that when the patient is very unwell with poor peripheral circulation, it might not give a very accurate blood glucose reading. And therefore one has to be careful when you interpret the results. So the continuous glucose monitoring check the interstitial glucose level that obviate that problem. And also it helps you to uh, determine the direction and magnitude of glucose trends, and also reduce the glycemic variability. There is some evidence suggesting that continuous glucose monitoring helps to reduce the incidence of hypos. And this, of course, some other studies did not sort of confirm this evidence. Um, what type of insulin and how do you give insulin when the patient is critically unwell in the ICU setup? The treatment of choice, of course, is intravenous insulin infusion. But as you know, it has to be done properly, and monitoring has to be uh, really intense to avoid fluctuation. And it's more effective in achieving glycemic target if we do it properly. And also it's important to use validated protocols for your settings. And this is what we use in the hospital that I work. There are three color-coded protocols, the green one, yellow one, and brown one. You start with the green one, where you start a relatively low dose infusion rate, and then you look at the blood glucose trend and to see whether the blood glucose are within the target range. If it is not, you may have to increase the dose, move on the direction of yellow and brown protocols. And also the other thing that we looked at is the blood glucose, how it declined, whether there should be at least 2.5 millimoles reduction in blood glucose level over a period of 1 to 2 hours. If the reduction of blood glucose level is less than 2.5, you may have to escalate the infusion rate. So using a validated protocol certainly helps to improve the blood glucose control. And this is the CGM blood glucose chart, just to show that the fluctuation of blood glucose level with various intervention. When you increase the infusion rate or decrease the infusion rate, it either increase or decrease the blood glucose level. When you start enteral feeding, it goes up very quickly. So you have to sort of anticipate this early and adjust the insulin infusion to avoid these fluctuations. So transition from intensive care to general care is extremely important. Unfortunately, this is often overlooked and there are no proper handover, and patients from intensive care unit sometimes land in the general medical ward without much plan. So it is very important that this transition period is managed very carefully. The care team changes, so the new care team take over the care of the patient. So they need to be very well informed. The good communication is important. And when the patient moves from intensive care unit to general medical unit, obviously the patient to nurse ratio changes, and intravenous insulin therapy may not be suitable in general medical ward, and you can't give the same attention for those patients in general medical ward. Hence, it is very important to change to a subcutaneous insulin before you transfer the patient from intensive care unit to general medical ward. And also you need to look at and these patients, their diet changes as they recover, and the tube feeding discontinued, and steroid doses usually tapers as the patient improves, and the counter regulatory hormone responses become less and less. All these contribute to the blood glucose level, and you need to take everything into consideration when you adjust the insulin dose for these patients when they transit from ICU to the general medical ward or the step down unit. So it is important to use validated transition protocol. It has been shown that using validated protocol during this crucial period help to reduce the mortality and morbidity and hospital stay. It's very important that when you change intravenous insulin infusion to subcut, the patient should be given the basal insulin at least 2 to 4 hours before you discontinue intravenous insulin infusion. And also the base bolus insulin should be given about 1 to 2 hours before. The reason being that if you discontinue and give, there will be a period in which there won't be enough insulin to control the blood glucose level. Hence, the patient will end up in having hyperglycemia, and then it will be very difficult to control later on. So what we normally do is when we change from intravenous to subcut insulin, we calculate the dose based on prior 24-hour infusion need. And suppose if the patient requirement for the past 24 hours is, say, for example, 100 units, you take 80% out of it. So 80% of 100 is 80 units. And you divide 8 units between the bolus and basal. So you give 50% of basal and 50% of bolus insulin. And as I mentioned earlier, it's important to give insulin, the basal and bolus, prior to discontinuation of intravenous insulin infusion. So the 50% of what we normally do is, if the basal is insulin glargine, you give in this particular example, so it's 8 units. You divide 8 units into 50 is 40 units of glargine. If you're using NPH, it's 40 units of NPH, and then the other 40 unit divide between the 3 main meal, depending on the carbohydrate intake. If someone who takes more carbohydrate for breakfast, you give more bolus insulin prior to breakfast, and less for other meals. And we try to keep the blood glucose level less than 180 in ward patients. Avoid oral hypoglycemic agent during this period. It's very important when someone who is unwell, they normally don't take orally, and their oral intake is minimum, and they may be dehydrated, and they may have acute kidney injury. All these things play a part when you decide what type of medication that you give to reduce blood glucose level. So insulin therapy would be the treatment of choice until patient recover completely. Especially the SGLT2 inhibitors should not be given when the patient is still recovering, because of the risk of euglycemic hypoglycemia, especially when the patient does not eat and drink as usual. The sliding scale alone has no place in managing diabetes in general medical ward. However, though, it might help you to supplement your basal bolus regime, but standalone sliding scale should be avoided. So in nutshell, hypoglycemia is common during critical illness and is associated with increased mortality and morbidity. It remains still unclear whether hypoglycemia is either a marker or a mediator of higher mortality and morbidity. Mitigating hypoglycemic variability is important, along with the relative hypoglycemia, and and try to avoid hypoglycemia as well. So achieving higher time in target blood glucose range helps to improve the survival. Glucose control during the transition from the ICU to intermediate care or general ward require very the coordination and the communication between the care providers. Approach to hyperglycemia should be individualized. So there's no one size fit for everyone. So uh, true that majority of these patients, our glycemic target would be between 140 and 80, but some patients probably need a more stringent approach and some patients need less stringent support. Hence, the glycemic goals or glycemic target should be tailor-made. The question is, should the strict glycemic approach be completely abandoned? I think the jury is still out on this issue. Perhaps in future it might revisit with the wide availability of a continuous glucose monitoring system along with closed loop system and computerized insulin algorithm. In fact, there has been few trials ongoing and the preliminary results are encouraging. Thank you for your attention. Let's go back to the question again and let's see whether we can answer the question better now. So can we have the first poll, please? So I suppose you can read for yourself. Excellent. Can we have the second poll, please? Well done. Very good. We'll have the next poll, please. Very good. I think we will have the last one. All right, thank you. Thank you for voting. And I think we do have a couple of minutes. I'll quickly go through the question and answers. Um, the stringent glycemic control, that is BGL between 4 and 6 or 70 and 110 milligram per liter in critical ill patients across the board have been shown to reduce mortality. In fact, it's conflicting results between the randomized control trial. So there's no, this statement is false. Across the board, there is no reduction in mortality, only one study which shows reduction in mortality, and most of the studies did not show any reduction. It shows either increased mortality or no mortality benefit. The major RCTs on glycemic control in critically ill patient in agreement with intravenous insulin therapy to achieve tight glycemic. It has to be not intravenous, it should be intensive insulin therapy to achieve tight glycemic control to improve prognosis. That's again wrong. That's because the evidence are not uniform between the randomized control trial. Treatment with SGLT2 inhibitors have been shown to improve cardiovascular mortality and morbidity in critical ill patients. Well, this statement is true until it comes to critical ill patients. So we don't use SGLT2 inhibitors in critical ill patients, but of course, SGLT2 inhibitors have been shown to improve cardiovascular mortality and morbidity, particularly among patients with the prior history of cardiovascular disease, but are not in critically ill patient. We don't use any oral hypoglycemic agents in critically ill patient. The treatment of choice, therefore, is insulin. There is unequivocal evidence supporting a causal relationship between high BGLs and increased mortality in critical ill patients. Unfortunately, there's no, it is not clear whether there is a causal relationship, but there is a relationship between high blood glucose and mortality and morbidity in critical ill patient, but whether it's a cause and effect relationship exists, not known. So that's again, it's not true. A critical patient without a prior history of diabetes or pre-diabetes do not develop hypoglycemia during acute illness. That is wrong. Again, stress-induced hypoglycemia is defined as hypoglycemia occurring in a non-diabetic patient. I think that's it. Thank you for your attention and voting for those questions as well. I mean, if you have any question, I'm happy to answer if you have time.
Yeah, thank you, Dr. Hewage, for that interesting, interactive, and evidence-based teaching capsule. Do you have any questions from the audience? Yeah, so apart from a question, someone mentioned, thank you very much for your very informative lecture. And there's a question, how do we change to mixed insulin from insulin infusion since we have mixture in Sri Lanka?
All right. Well, this is not the optimal insulin to change from intravenous insulin infusion. So if you have short acting, say, if you don't have rapid acting insulin such as insulin aspart or Humalog, just use Actrapid with intermediate acting insulin like NPH in the form of basal bolus. That is the best. But if you don't have even that, then of course then you need to calculate the dose, the formula that I just mentioned. So you look at the prior 24-hour insulin need and take 80% of that and then divide into long and short acting. 70 mixed has 30% of short acting and 70% of intermediate acting. So if you take 100 units of mixed it has 30 of Actrapid and 70 of intermediate acting insulin. So then you need to do your maths to decide the dose, and then mixed is given twice a day. It depends again on the main meal, what time the patient takes. So if the main meal is breakfast and lunch, you give about 2/3 in the morning and 1/3 at dinner time. Or if the main meal is towards later in the day, you can divide into half and half. It depends on what time the patient has most carbohydrate. So it has to be individualized. So you use your basic principle to calculate the appropriate dose for your patient.
Yeah, thank you. And I have a question. Like now, we see patients with, now, for example, a pregnant patient who develops diabetes during the pregnancy have a tendency to develop diabetes in the long run. But now you talked about the stress-induced hypoglycemia, especially in critical ill patients who have developed stress-induced hypoglycemia during the critical illness. For example, for some time during the ICU stay, have they have a chance of developing diabetes in the future?
Well, it's a good question. Well, if you take pregnancy as a stress, it's a different kind of metabolic stress to the body, and it has been very clearly shown that the patients who have had gestational diabetes are at a greater risk of developing diabetes in future. But however, there's no studies been done for people who develop hypoglycemia during critical illness to see whether they develop diabetes in future. I could not see any evidence to say that, but my gut feeling is that probably it's another type of stress, and perhaps these patients are more likely to develop diabetes in future. So once the patient recovered from critical illness, it's not a bad idea to keep an eye on the blood glucose level and take precautions to prevent diabetes in future.
Thank you. Yeah, I think you correctly mentioned that during the lecture, the protocolized and probably maybe we are heading for an individualized therapy in the future. Probably now all the treatment strategies are probably going for individualized or personalized therapy, I believe.
That's true. I think the diabetes, the management of diabetes becoming very individualized now. We do have a lot of the medication in to treat diabetes. So it is an individualized treatment strategy for whether its patient has critical illness or not. So you need to look at the patient in front of you and look at the comorbidities, how the seriously ill the patient is, and then and look at your own the hospital environment. Do you have enough facilities to provide the optimal treatment for the patient? So all these factors need to take into consideration when you start a management plan.
Yeah, thank you very much for that talk. And I would like to again thank you, Dr. Hewage, for that interesting lecture. And we're going to close this teaching capsule, and we're going to have a break now and go on for the symposia. Thank you very much.
Thank you very much.